Hello, HSC 110, Medical Terminology and Body Systems. This is Dr. Teresa, and we are going to dive into the endocrine system, which is chapter 9 in our book, and it begins on page 273. This is probably my favorite system. Of course, I think I say that a lot. This and the nervous system are high controllers of homeostasis. So the organs, their constructs, the way they're intended to work, and the information carried from these systems to the rest of our body is really one of the primary drivers and dictators of all systems and how all systems communicate with other systems. So as we dive in, we'll talk about endocrine glands. These are glands. If you recall our delineation between endocrine or endocrine and exocrine glands, okay? Endo tells us that that's happening on the inside. The exocrine gland is something that will have a duct with a secretion to an external lining or surface. So an endocrine gland will secrete, or I think it like oozes its product out into the local periphery, which then gets carried away into the bloodstream and received by whatever is capable of receiving that message and receiving and or responding to a particular hormone. So it will secrete its hormones into the lymph. The glands don't have the ducts that the exocrine glands do. They will be well vascularized because of the fact that they have to be able to send their product via the bloodstream for communication purposes. The hormones, okay, these are chemical messengers, again, that we send directly into the bloodstream. The major endocrine glands within our system will include the hypothalamus, the pancreas, pituitary gland, adrenal glands, thyroid, parathyroid, thymus, pineal gland, testes, and ovaries. So a couple things I want to point out here. Your testes and your ovaries can also be classified within the reproductive system, but they are also endocrine organs and construct. The pancreas is classified also as one of your digestive organs. Your thymus gland, that is part of your lymphatic system also. So we're seeing that a lot of these glands will have multiple placements in multiple body systems. Again, when we talk exocrine glands, okay, just for contrast, they have ducts. They secrete their product through the duct directly to a surface. That can be the lumen of a vessel or the lumen of an organ, by the way, or like onto the skin, okay? Anything that has a duct. So examples would be sweat glands, salivary glands, mammary glands, the lacrimal glands that we learned about in our last chapter. The pancreas has functions of both, interestingly. It has parts of it that will have an exocrine release and an endocrine production and release. Hormones. This is really relevant to understand here, what they're constructed of. So when we're considering hormones, they are constructed by or regulated by the presence of carbohydrates, fat, and protein, or they have an impact on that. They will be, okay, they will be regulated by and help regulate these things. They will impact water and electrolyte balance. They'll have an impact on reproduction. They are the reason we grow and develop, part of the reason. They have a heavy hand in energy balancing and are going to be responsible for response to infections and stresses. Now, in order to produce a hormone, because of what they're involved with and what they're made of, we need to have certain elements in our diet, one being cholesterol, by the way. Every hormone in your body has some type of lipid construct to it. So that has big implications down the road. So what I'm trying to get at here is that cholesterol, and we mentioned this when we were back in our chemistry section, is that it is in every cell, and our cholesterol can be part of our hormones and other really, really necessary components of our physiology. Therefore, should not be just shut off without further inspection, I feel. Now, when we talk about hormones, I mentioned that they get secreted and then they'll take a message to whoever wants to hear it, kind of. Not every hormone will be received by every cell. It depends on the type of cell in a particular tissue in a particular organ. So if the hormone that is secreted gets received by a particular cell, okay, it will then, this message is received, picked up, and then something's going to happen in response to that stimulus. So when we talk about a target cell, it will have a particular receptor for a particular hormone. And you can have the same hormone picked up. You can even do this with neurotransmitters too, okay? They get produced and secreted and received, and the action from the target cell or the receptor delivers a completely different response depending on the receptor, if that made any sense. So some hormones, like epinephrine, which also functions as a neurotransmitter or can, have receptors at many different sites, making their effects widespread. And other hormones will have fewer target sites, which will limit their impact, their effect, and what they're able to do. So fat-soluble lipid hormones are called steroid hormones. When we talk about something that is fat-soluble, it has to be dissolved by or in the presence of a fat in order for it to be dissolved. Water-soluble hormones are composed of protein or protein-related substances, and these are called amino acid-derived hormones. Now, because they're water-soluble, they have to have a polarity to that molecule, to that type of hormone, and that's why they're able to do that. Most hormones are amino acid-derived hormones, except the hormones of the adrenal cortex and the reproductive glands. The structure of them will determine how it travels. So the amino acid-derived hormones will go alone, but the steroid hormones, the fat-soluble ones, will require a carrier. Fat-soluble hormones cannot move through water easily because it's, something polar, water, and something non-polar, lipid derived, okay? It's like the oil and water analogy. Amino acid derived hormones cannot pass through a lipid-containing cell membrane, but the steroid hormones do. The amino acid-derived hormones are the ones that will require a receptor on the cell's membrane in order for it to be received and the message taken and carried, and whatever chemical events happen downstream from that will be inspired. The structure of a hormone will also determine whether it will bind with a receptor or inside the cell. So the structure is hugely important, as we're seeing, not only for transport, but delivery from outside of a cell to inside of a cell. Our steroid hormones will have a different function based on where they bind on a receptor. Steroid hormones can diffuse through a membrane due to the fact that they are lipid soluble. The steroid hormones are secreted, again, by the reproductive glands and the adrenal cortex, and transported by protein carriers wherever they need to go. Once this hormone complex reaches its target, it binds to the protein receptor inside the cell and forms a hormone receptor complex. This then is able to get into the nucleus. This has the potential to turn on gene expression, to get something activated. We turn on gene expression to do what? We do that in order to build proteins. So basically, if we have these steroid hormones bust through the system on a protein carrier, gets taken to the cell, gets accepted into the cell, it forms a complex once in the cell within the cytoplasm. Then that gets driven to the nucleus where there's a receptor for this complex. It's pulled into the cell, and then it gets to activate or is able to stimulate and activate DNA. Pretty cool. And that has huge implications. So let's walk through something just real quick. We talk about stress, we talk about inflammation, we talk about chronic disease states. Anything that will inspire a hormone response, specifically these guys, okay, reproductive and adrenal cortex, has the capacity to change your genetic expression, is what we're saying here. So this is highly relevant. The presence or absence of the production of these steroid-based hormones can dictate the manifestation and or expression of disease, disorders, illnesses, or deficient function. We could even say it like that. Now, when we talk about the amino acid-derived hormones and what they're here to do or what they're better at doing, remember that these guys have receptors right in the cell membrane. They can't enter the cell, so there's what we have, or what we call that second messenger system. I think we touched on this in the chemistry section. Okay, it has a receptor for an amino acid-derived hormone. It will be able to pull it into the cell. The product, it gets kind of shipped into an assembly line where its chemical energy is utilized for other processes. So the amino acid-derived hormone is considered the first messenger. The process will begin when a hormone will bind with that surface receptor to form a hormone receptor complex. and then create a series of reactions, which ultimately will activate an enzyme. The activated enzyme creates a second messenger, which has the ability then to work inside the cell. So slightly different than the steroid hormones in how it gets to that second step, or how it gets to the phase where it's able to produce something that inspires responses in the cell. So when the amino acid derived hormone binds with that surface receptor, it will activate the enzyme adenylene cyclase. Adenylene cyclase will stimulate the formation of something that we call cyclic adenosine monophosphate, or cyclic AMP, CCAMP. This cyclic AMP will activate the protein kinases with energy supplied by ATP, which will produce a cascade of responses that range from activating enzymes to causing protein synthesis and glycogen breakdown. Now, there are other second messengers that could be there rather than just the cyclic AMP or the CCAMP. And it could be something called cyclic guanosine monophosphate, inositol triphosphate, and or calcium ions, to name a few. So that second messenger can be a variety of different compounds used to then inspire other responses and actions within the cell. We have to talk then about upregulation and downregulation. The activity of a hormone receptor can be upregulated, increased, or downregulated, which is a decrease, making them more or less sensitive to hormones, respectively. And upregulation is increased activity. So exercise will make us more responsive to insulin. A downregulated hormone receptor will have the ability to decrease the activity. So within obesity, it will require more insulin to be produced. Okay, when we talk hormone control, okay, where does the process begin? Who tells what to do? How do we know? Okay, hormones, this whole endocrine, it's the neuroendocrine system, which again, highly responsible for your homeostasis ability. But also, these are your stress responders of all kinds. And I don't mean just emotional stresses. As we've talked through some concepts, yes, emotions are hormones. Okay, that is the biochemical packet of your feelings. There is something in there when we have a feeling, an overwhelming feeling, or waterfall, okay, of emotions. There's going to be a high charge of hormone control. Now, what starts the cascade? Where does it begin? Some stressor, real or imagined, interpreted or uninterpreted, seen or unseen, okay, it's happening all the time, and all the time, whether you know it or not. You have things impacting you that you're not aware of, okay? Or that you can't maybe consciously interpret. Sometimes you might not even feel it. But this is happening all the time. So what happens is there will be some type of sensory input coming into your body. This could be sunlight. This could be sound. This could be food. This could be someone touching your arm. This could be someone speaking to you. That input then gets directed to your central nervous system, brain, and spine. This is going to have an impact then, or dictate the hypothalamus. The hypothalamus is responsible for releasing hormones. When the hypothalamus releases hormones, it's going to then direct or dictate the pituitary gland to release more or different ones. So the hypothalamus directs the pituitary gland, which then will dictate the release of other hormones that get shipped out. Now, when we talk about the pituitary gland, it has an anterior pituitary, or what we call the adenohypophysis. This is actually an upgrowth of your pharynx, embryologically. And then you have the posterior pituitary gland, which we call the neurohypophysis, which is like a downgrowth from your brain. Okay. Within these two divisions of your pituitary gland, there are different hormones produced. There are 8 in total. 6 will be produced and released by the anterior pituitary, and then 2 of them get stored in the posterior pituitary. I'm going to say stored. So the hormones of your anterior pituitary, we'll talk about these a little bit more in a second, are ACTH, TSH, FSH, LH, GH, PRL. The 2 hormones of your posterior pituitary are oxytocin and ADH. Now, once the pituitary gland is inspired to release a particular hormone in a particular quantity, that gets shipped out via the bloodstream, okay, all over the place, and hopefully gets to the target, right? It gets to the receptor on wherever it needs to get, sending a message. So those receptors may be the adrenal cortex, the thyroid, the ovaries, and testes, okay? The adrenal medulla, by the way, and I believe we mentioned this, the internal, or if we didn't, we're going to mention it here, and we'll mention it again, likely when we get into the renal chapter. The internal portion of the adrenal gland is really a sympathetic chain ganglion responsible for the production of our catecholamines, which are epinephrine, norepinephrine, okay? So the adrenal medulla, the internal portion of the adrenal gland, which sits on top of your kidneys, is responsible for your partly responsible for the conduction and regulation of your fight or flight responses. So there's a direct link to your central nervous system in case you have to run or fight a tiger, right? Run from or fight a tiger. So the hormonal control of our endocrine glands and organs is achieved through a hierarchy or chain of command. And we just walked through that hormonal control. The hypothalamus does this through the secretion of hypothalamic releasing hormones and hypothalamic non-releasing hormones, by the way. Again, they stimulate the pituitary in order for the pituitary to get directed or dictated to do its job. The endocrine system will achieve humoral control by monitoring the levels of various substances in body fluids, such as the blood. So if it detects a homeostatic imbalance, it initiates the corrective action. Now, this kind of goes into negative feedback loops, okay? So it will send out these chemical messengers. Once it receives indicators that homeostasis is good or not so good, this will dictate either further inspiration of release of more hormones by the hypothalamus to the pituitary and so on and so forth, or it'll shut it down. Okay, so for example, if blood sugar rises, the pancreas will secrete insulin. Insulin then will stimulate the absorption of glucose by the cells of the body, which will inherently then lower the blood levels of insulin. When the blood glucose levels drop, then in contrast, the pancreas does a secretion of a hormone called glucagon. Glucagon causes the breakdown of glycogen that is stored in the liver. The glycogen then can enter the bloodstream and increase the glucose levels. When we have neural control of the hormone release or secretion, this is nerve fibers that will stimulate endocrine glands. This is the least common mechanism, but this is what I was talking about in regards to your fight or flight response. When we have our fight or flight response inspired, and then just a reminder of how this works within the nervous system, okay? This is sympathetic nervous system. So that's your fight or flight portion of your autonomic regulation. It will increase your heart rate, increase your blood pressure, increase your respiratory rate, and increase flow to muscles. Because you're deciding in sympathetic nervous system tone or fight or flight whether to run from a tiger or fight it, like you're not worrying about digesting food. So immune system function will decrease in that instance. Digestion decreases and urination decreases because, again, it's worried about your heart pumping, your muscles working in case you have to run or fight. Now, the hypothalamus also controls your thermostat. When your temperature falls beyond or below a set point, your body's going to regulate that to keep temperatures relatively in the same space or same rate. So you're going to have indicators and feedback loops regarding temperature in varying areas of the body. Your hypothalamus is your thermostat and wants to make sure that you stay at 98.6 degrees Fahrenheit or 37 degrees Celsius. If your temperature drops below 98.6, your hypothalamus will release hormones that act on your thyroid gland. The thyroid gland will produce thyroxine, which is a hormone that increases metabolic rate and heat production. By the way, a couple of these hormones will be are in your quiz that I've mentioned. Okay. The hypothalamus also stimulates that sympathetic nervous system, which may initiate a shivering. It will decrease blood flow to the skin, but its intention is to increase that internal temperature. When the body's thermal receptors sense that there's an increase in body temperatures, then your hypothalamus will send signals to make sure that you're producing sweat. Due to the fact that sweat is primarily water, and water is a great conductor of heat as well as electricity, putting that on your skin will take some heat with it. That's why we sweat. Okay, let's go into some of the organs. There's a nice chart on page 283 in your book. You can kind of look over that as we go through this. So the pituitary gland, I already mentioned, has an anterior and posterior lobe. It is located within the sphenoid bone. If you recall back in our bone identification, we had a depression in the sphenoid bone called the sella turcica, and it's right in there. When you look at a brain and you find the pituitary gland, it's one of the easiest things to find because it's like sticking down on that's a little ball that sticks down on a little stem. It looks like hanging out of the brain. That infundibulum is the little stem part. We do call the pituitary gland the master gland because it controls the activity of the pituitary gland both through the hypophyseal portal blood system, which is part of the anterior pituitary gland secretion process, but also through neurosecretory cells of the posterior pituitary gland. The hypothalamus and the pituitary glands together have a greater effect on endocrine activity than any other part of the endocrine system. The hypothalamus itself is very small, and it's deep within the brain, below the thalamus, hence the name hypothalamus. The job of the hypothalamus is to, again, collect information. So it's receiving that information about the stimuli in the body and then directing and dictating a response. Although the hypothalamus is part of the nervous system, it's also a key part of the endocrine system as we're learning because it produces hypothalamic releasing hormones and non-releasing hormones that we mentioned. So when we say that hypothalamus is responsible for having something be released or having something be stopped being released. So again, these feedback loops where it gets told what to do is relevant for its regulation of what's happening downstream. So here's an example. The hypothalamus will secrete TRH or thyrotropin, which will flow through capillaries connecting the hypothalamus to the anterior pituitary. This is the hypophyseal portal system that I referenced. The TRH will reach the pituitary, stimulate the gland then to release thyroid stimulating hormone or TSH. So it's TRH is the releasing hormone and TSH is what it inspires the thyroid to release. So we mentioned let me talk real quick 1 second about let's go back to the hypothalamic hormones and mention the ADH and the oxytocin because they're relevant. Again, when we talk antidiuretic hormone is going to help reduce filtration in the kidneys, helps you urinate less. It is stored and released from that posterior pituitary gland as well as oxytocin. Oxytocin is the hormone that gets released when we have those first feelings of love and attachment. It's an attachment hormone, okay? Baby bonding, partner bonding, like attachment, okay, is an element of oxytocin production. Okay. This picture here is on page 284 in your book. Nice little chart just to give you an idea again of how that's going to work, that action of the anterior pituitary gland. There's no nervous system connection between the hypothalamus and the anterior pituitary. Excuse me. The hypothalamus causes the release or inhibition of hormones from that anterior pituitary, like we mentioned, by way of that hypophyseal portal system. This is a capillary network in the hypothalamus that reaches into the portal veins that carry blood to that anterior pituitary gland. The hormones secreted here function in two ways. They either will act directly on a tissue, as in the case of prolactin and growth hormone, or they can stimulate an endocrine organ to release certain hormones. So pituitary hormones that stimulate other endocrine glands, we call them tropic hormones or tropins. So that would be like TSH, okay, thyrotropin. So again, the anterior pituitary releases 6 stimulating hormones, and the posterior pituitary releases 2. The 2 of the posterior pituitary, again, are ADH and oxytocin. The 6 of the anterior lobe of the pituitary gland are growth hormone, or GH, prolactin, or PRL, adrenocorticotropic hormone, ACTH. And you can, like we just said, anything that's tropic will have it in its name, okay, the name of the hormone, which tells us that it came from an endocrine gland that was inspired to release it. Thyroid stimulating hormone, TSH, also called thyrotropin. Follicle stimulating hormone is FSH, and luteinizing hormone is LH. Hope that made sense. So within these tropic hormones that we're discussing, the ACTH, adrenocorticotropic hormone, acts on the adrenal gland to stimulate the release of steroid hormones. That TSH, or thyrotropin, thyroid stimulating hormone, stimulates the thyroid gland to release thyroxine, which is T4, and triiodothyronine, which is T3. Follicle stimulating hormone, or FSH, will stimulate the ovaries to produce estrogen and stimulates the testes to develop sperm. Luteinizing hormone acts on ovaries to produce progesterone and estrogen in women. In men, LH will stimulate the interstitial cells of the testes to produce testosterone. So same hormone, different targets, right? Because it's in different individuals, different genders, doing different things. That's relevant. So FSH and LH are further categorized as gonadotropic hormones because they are specific to the gonads, and gonads are, yes, testes in male, but also ovaries in females. So just to review some of that medical terminology, again, ACTH, TSH, FSH, and LH are the tropic hormones of the anterior pituitary because they produce gonadotropes, cells in the anterior pituitary. Tropic hormones act on other endocrine glands, not on body tissue. Now, growth hormone is not tropic. It is secreted by somatotropic cells, but works right on the tissues. It's responsible for growth of muscles, cartilage, bones. It also helps break down fat. So, growth hormone can be released in a person that is exercising. It also increases the concentration of glucose in the body and can stimulate fats and proteins to be converted into glucose by the liver. This process that growth hormone helps with is called gluconeogenesis. If you break down that word, that should help us out with making new sugar. When we talk about prolactin, it's secreted by the lactotropic cells in the anterior pituitary and will stimulate the growth of mammary glands and the production of milk in a nursing mother. The prefix pro means for, and the combining form lacto means milk. So prolactin is also in males, but its role isn't clear, obviously. Okay, I already mentioned at least twice, okay, that ADH and oxytocin are products of the posterior pituitary gland. These hormones are transported through nerve fibers along the neurosecretory network that I had mentioned as well, that connect the hypothalamus to the posterior pituitary. These nerve fibers will arise in the hypothalamus and pass down the infundibulum as a bundle called the hypothalamo-hypophyseal tract. Okay. So in the anterior pituitary, we have the portal system of capillaries and blood, okay, because the function's a little different. In the posterior pituitary, we have the hypothalamo-hypophyseal tract, bringing information or neurologic stimulus from the hypothalamus into that posterior pituitary to inspire the release of either ADH or oxytocin. And actually, the posterior portion of the pituitary isn't necessarily classified as an endocrine gland because it doesn't do its own production. It's a storer and secretor. I mentioned that ADH was the anti-diuretic hormone. Okay, if you take a diuretic, it will help you urinate. Anti-diuretic will regulate diuresis. ADH will travel in the blood to reach its target organs, including the kidneys, but also sweat and eccrine glands. It's one of its big roles, and we'll learn this in the renal chapter, is to increase the water absorption by the kidneys. This is to help regulate blood pressure. It will decrease sweating. That makes sense. It's subject to humoral control. It's also secreted when solid particles in the blood become too concentrated. So again, we're trying to regulate blood pressure, and in understanding how blood pressure works, the thickness of the blood or the viscosity will be part of the control of blood pressure. And in order to have hydration appropriate or enough water in the system, or not too many electrolytes, this is all part of that control. We'll learn that better in the renal section. Oxytocin, I already mentioned. Oxytocin actually helps or is produced during labor. It will help facilitate childbirth by helping the uterus contract. Now, this is a positive feedback loop, okay? Meaning when the uterus starts contracting, because the posterior pituitary has received the appropriate signal and it's being released, it's going to keep going until there's another feedback loop that tells us this baby's born and it can stop doing that. Again, it will help the mammary glands secrete milk. Now, our thyroid gland. The picture on page 288. The thyroid itself is bilobed. It has that center bridge part called the isthmus. The larynx sits above it, and your trachea sits below it. The thyroid gland will secrete 3 hormones. So let's talk through some of them. Okay, it has specific cells called C cells that will produce calcitonin. Calcitonin helps regulate calcium within the blood. So thyroid hormone includes T4 and T3. We already mentioned. Thyroxine is T4. Triiodothyronine is T3. These are secreted by follicular cells of the thyroid into a network that surrounds each follicle. I think we already know the thyroid hormones, or maybe you don't, or these hormones are associated with your metabolism. And we'll talk shortly here about things that can go wrong. Every cell in the body is affected by thyroid hormones because every living cell needs energy to survive. If these guys impact metabolism, okay, your cellular metabolism, how your cells are able to convert glucose to energy, highly relevant. T4 and T3 are formed from 2 linked amino acids called tyrosine with an iodine atom attached. T4 has 4 iodine, T3 has 3. T3 is our active form of thyroid hormone. The iodine that is required to make T4 and T3 comes from dietary intake. Iodine is one of those trace elements that you have to have it. We don't store it well, but you can't, an overload is not functional either. This is something that we just need to get on a regular. So the release of the thyroid hormones is controlled by the hypothalamus, okay, as it's receiving information about what's happening downstream cellularly. So if there's not enough T3 floating around or active, your thyroid gland will spit out TSH, thyroid stimulating hormone, in order to try to get this to happen and inspire a negative feedback loop. The negative feedback loop will then receive like, hey, we have enough here, we're good, and shut the TSH off. So I mentioned calcitonin was the other hormone that is produced by the thyroid gland, by the C cells of the thyroid gland. The parafollicular cells, these are located between the follicular cells in the connective tissue of the thyroid. Calcitonin, along with parathyroid hormone, help maintain calcium levels in the blood, which I already mentioned. Parathyroid glands. So you have 4 parathyroid glands. They're sitting on the posterior aspect of your thyroid gland. These are tiny little guys about the size of a grain of rice, but they secrete a very important hormone. It's called parathyroid hormone. It is responsible, or partly responsible, for helping increase blood calcium levels. It will help stimulate the breakdown of bone if we need minerals. It will help increase calcium absorption within the intestines and also stimulate the kidneys to hold on to calcium rather than filtering it out. The adrenal glands. Oh, let's stop and talk about this real quick. So the regulation of calcium, blood calcium levels. You have a picture of this on page 290, okay? So the thyroid gland, again, if calcium levels are too high, the the thyroid gland will release calcitonin. Then the bones will increase their calcium deposition. The intestines won't pull calcium back into the system. And there will be decreased calcium reabsorption by the kidneys, meaning it's going to let it pass. It's going to let all that stuff pass until the blood levels of calcium are re-regulated. Vitamin D plays a role in this as well. Okay, vitamin D, when it gets hit with UV light, which is necessary, helps regulate this whole process as well. Now, the parathyroid glands acts in contrast to that. So if the calcium levels are too low, they're going to inspire release of calcium from the bones. They're going to tell the intestines to pull calcium back into the system, and they're going to tell the kidneys to pull calcium back into them. So let's get to the adrenal glands. These are my favorites. If you have an adrenal issue, by the way, you're going to have a thyroid issue and vice versa. They don't work on totally separate looping systems. You have what's called the hypothalamic pituitary adrenal axis, and then you have the hypothalamic pituitary thyroid, HPT and HPA. They each have their own axis, but they're, again, this is one of those cases where we try to separate everything and they're really intimately intertwined. So as we talk about the adrenal glands, these guys, again, they're like little triangles that sit on top of our kidneys. They do have a cortex, or that outer layer, and then they have a medulla, or that inner layer. So what we're getting to look at here is the histology, or a histology slide of an adrenal gland. We can see within the medulla, again, of the adrenal gland is the creators of our catecholamines, epinephrine and norepinephrine. So they are primarily directly connected to your central nervous system, and they're controlled via sympathetic nervous system tone. That adrenal cortex, this is where we do a lot more steroid hormone building and secreting. Sex hormones are secreted closer to the medulla. Then we have glucocorticoid secreting area, which is right in the middle of that adrenal cortex, and what we call mineral corticoids, which would be the outermost layer of the cortex and its production and what a particular cell type is going to do. Okay, so when we're talking about the release of products from the adrenal glands, let's go into what they are. So the principal mineral corticoid is aldosterone. It is responsible for regulating our blood pressure and plasma volume by way of impacting the kidneys and what they're regulating primarily. Now, the secretion of aldosterone is regulated by something called renin and angiotensin. It will be regulated by sodium and potassium levels. It will be released by response to stresses of all kinds and regulated by blood pressure and volume. So it will be like a feedback system, right? Trying to regulate and dictate. Decreased blood volume and pressure will activate baroreceptors, which are pressure sensors within our vascular system that will stimulate the kidneys to secrete something called renin. This will create a cascade that will convert a substance called angiotensin 1 to angiotensin 2. And the angiotensin 2 is a powerful stimulant for the aldosterone secretion by the cortex. If you look at page 292 in your textbook, we can see a map of how the angiotensin, the renin-angiotensin 1 and 2 system is regulated, activated, and how that's going to impact the regulation of the kidneys in regards to minerals as well as water balance. Increased blood pressure and blood volume also will alter aldosterone secretion. It will increase the blood pressure and volume, cause the atria fibers of the heart to stretch. When this happens, we have the release of something called ANP, or atrial natriuretic peptide hormone. ANP will inhibit the release of aldosterone, which will cause less sodium reabsorption and therefore less water retention in the blood. Glucocorticoids. These are cortisone and cortisol. We've heard a lot about cortisol. This will help us maintain glucose levels. They do actually have anti-inflammatory properties in the short term, but they can decrease your immune system. So we think of cortisol as a stress responder, right? Universal stress hormone noted in the fight or flight response. Now, chronic release of this of cortisol has some different impacts on the body as things progress. Chronic stress exposure can come from, as we know, anything, but they're with the release of cortisol on a chronic level, which means 6 months or longer chronic exposure, or something that is chronically repeated. It can lead to heart disease, stroke, GI issues, diabetes, reproductive issues, and anxiety, and can lower the cancer survival rate. And I think that makes sense if we understand that it has an impact on our immune response. So relevancy and immune system stuff, right? We don't want to be under high stress. Here's the biochemistry, or part of the biochemistry of it. Okay, that sympathetic nervous system reduces our immune system function. So if we're fight or flighting it chronically, or if we're in fear or panic, doesn't have to even be a real, it's real or imagined, gang. I will say that over and over. Okay, when we get to the sex hormones, okay, the adrenal cortex secretes mainly what we call an androgen, which are male sex hormones, primarily testosterone and small amounts of estrogen. The reproductive organs will also produce sex hormones. The adrenal cortex will continue to produce the same amount of androgens, okay, throughout life, regardless of what the reproductive system is up to, which is part of the production of like female facial hair with age, okay, as their reproductive organs are producing less of the estrogens, they're going to be producing more of the testosterone, and that's going to have its relevant effects. So the medulla, I already talked about this. The medulla is the inner portion of the adrenal glands. It produces catecholamines, epinephrine, and norepinephrine. When we have an adrenaline rush, that's what we're feeling. It very quickly will increase heart rate, blood pressure, breathing, metabolic rates, as well as glucose production. These hormones get released when stress of any kind will stimulate the hypothalamus to release corticotropin releasing hormone, or CRH, which then will trigger the anterior pituitary gland to release adrenocorticotropin, which then will stimulate the adrenal medulla to release the epinephrine and norepinephrine. To remember, or to help you remember the hormones of the medulla, just remember the acronym AMEN. Adrenal medulla secretes epinephrine and norepinephrine. So, okay, this I will talk about on page 294, just real quickly. With the little yellow box, the bionic pancreas. Or what we could call the insulin pump, okay, for a type 1 diabetic. First of all, you've heard of people with diabetes. You need to understand there are two types, type 1 and type 2, potentially more, okay, by the way. I could call it a type 3, possibly. Okay, let's just talk about 1 and 2. Type 1 is destruction of your beta cells of your pancreas, which are responsible for insulin production. These cells get destroyed for whatever reason. One thing we have to discuss is a genetic predisposition. You've heard me talk before that genetics, only about 20% of anything that manifests has a full-blown genetic representation. What that means is the other 80% is epigenetic, or depending on experiences and environment, something has the potential to express itself. So you can get type 1 diabetes in youth. That has changed significantly. And now you can get it in later years. Now they're finding that. Also, you can get type 2 diabetes, which generally was correlated with being older. You can get that way younger now. With an insulin pump, they are better, I would say, probably than older methods, because you didn't have all the technology. You didn't have the continuous glucose monitoring and the, with the glucometers, and you probably would have had to do urine checks repeatedly. But with the insulin pump, they now have sensors. The sensors can give information to an app on a phone. It's very computerized. Here's the thing. Do they fail? Yes, they do. Acceptable range of error is about 20%. Okay, that can be dangerous if you're in the wrong range. Okay, for a type 1 diabetic, personally, I feel that low blood sugars are more short-term dangerous. I don't even feel, I know they are. Okay, because if the pump is just spitting out insulin, which it does on a regular basis, and then you deliver larger doses of insulin via the pump to accommodate for any meal that you ate or whatever. But if your blood sugar is dropping low and you keep giving yourself more and more insulin, that's dangerous. Okay. On the flip side, if you have chronic high blood sugars that you're not regulating or pulling down within range, you're also potentially harming yourself. Chronic high blood sugars, there are multiple risks involved with that. You can go into what's called DKA, or diabetic ketoacidosis, meaning that your body is turning acidic and it cannot deal with it. Now, if you start becoming acidic, you're going to derange proteins, right? So that's the danger in that. And trying to protect the brain tissue from an acidic environment is kind of the goal. When we talk about the pancreas, okay, I mentioned the beta cells of the pancreas. Let's walk through a little bit of this, okay? It's located posterior to the stomach in the upper part of the abdominal cavity. Remember, I mentioned it has exocrine plus endocrine function. It's part of the digestive system as well. It will control blood sugar levels by the release of, well, multiple factors, but one of its primary functions is to release insulin. It does release other things, by the way. Its exocrine function is in the secretion of things into the small intestine, really. The hormone secreting cells of the pancreas are called the islets of Langerhans. The islets of Langerhans include the alpha and beta cells. The alpha cells secrete glucagon, which will inspire a release of blood sugar if you're in a functioning person with a functioning pancreas. You will just inherently inspire the release of glucagon if it's been detected that your blood sugar is low. Glucagon will go to the liver and make it release glycogen, which is your polysaccharide sugar molecule, okay, that we store in multiple places within our body. The beta cells are responsible for the insulin secretion. Insulin secretion will help a cell be able to bring glucose into it and utilize it. Once inside the cell, glucose is used for energy. I think we know that, but just reaffirming. So a person, I'll tell you this, with type 1 diabetes, when they have beta cell destruction, they likely also have alpha cell destruction. So they can't produce glucagon on their own either. So not only do they have insulin, but they will have a glucagon kit in order to be able to handle it if their blood sugar gets way too low, hopefully. Glucagon secretion is achieved primarily through glycogen breakdown in the liver, glycogenolysis, that's what that's called, or making glucose from proteins, which is gluconeogenesis. Remember the hormones secreted by the pancreas. Just remember the acronym PIG. Pancreas secretes insulin and glucagon. So we mentioned at the beginning, the thymus was also one of the organs of the endocrine system. It's responsible for producing something called thymosin, thymopoietin, and is responsible for the development and activity of T cells. It is both endocrine and lymphatic, as I mentioned. It lies under the sternum, anterior to the heart. It's large in youth and it shrinks as we age, of course. The pineal gland, I think this is a really cool gland. It sits kind of in the back of your brain, kind of. If you remember from the neurology section, it's responsible for the production of melatonin, which means that it's responsible for your circadian rhythms. So I think this is cool because if we understand that this guy is detecting light waves even when you're not consciously aware of them, I think that's a big deal. Also, we don't really understand the full capacity of this gland. We do think it has something to do with seasonal affective disorder, though, meaning then that there's going to be a vitamin D interplay. That's not separate. Now, the gonads I mentioned, testes in the male, ovaries in the female. The testes are responsible for producing sperm and androgens. The ovaries will produce eggs, estrogen, and progesterone. The kidneys also have a hormone that they produce called erythropoietin. Erythropoietin is necessary for the stimulation of red blood cell production. So as the kidneys filter the blood, they produce urine, by the way, and regulate blood pressure and, viscosity and calcium levels in the blood. They all it plays a part in that. As they're doing that, they're going to be able to detect then if the body is in need of more red blood cells. And if so, they can secrete erythropoietin to stimulate the production in hemopoietic tissue. Fatty tissue throughout the body will produce prostaglandins, and prostaglandins have a variety of roles. They help regulate smooth muscle, line blood vessels, respiratory passages, and stimulate the muscles of the uterus, but they also activate the inflammatory response. So having adipose tissue and lipids throughout our body is relevant in order to help inspire inflammation. However, I think we understand, or maybe we can make this connection here, that if we have too much of it, potentially we could have inflammatory responses triggered and hormone cascades triggered that don't need triggered. Adipose cells produce something called leptin. This is a hormone that helps regulate appetite by acting on the hypothalamus and controlling centers. And we think this plays a role in obesity. So in the fetus, let's start there and how then hormones will develop within the child and the relevancy. So in the first trimester, hormones dramatically will change in the fetus. One hormone involved is human chorionic gonadotropin hormone. This is only produced during pregnancy and is made by the placenta after implantation. So if you go for a pregnancy test, this is what we're looking for. Levels of HCG. It will support the structures of the corpus luteum, which is responsible for secreting estrogen and progesterone. And I don't know if you remember, the corpus luteum is kind of the wrapping paper of the ovum. So the body's great at not wasting anything. It will also rise in the mother's blood and urine, which is why you urinate on a stick or in a cup to take a pregnancy test, or you get a blood draw. Also, the rise in level of this hormone is generally responsible or thought to be responsible for nausea during that first trimester. There's also a hormone called placenta lactogen. This is made by the placenta, which provides nutrients to the fetus and will stimulate the growth of the mammary glands in the breast. Progesterone will relax the uterus so that the fetus can actually implant and remain intact. It also prepares the breast for milk production. Estrogen will aid in the development of the uterus as well as the fetus. The estrogen levels will continue to rise throughout pregnancy and peak in the third trimester. They will all decline with the placental discharge and the birth of the baby. Now, in children, the hypothalamus will begin to produce gonadotropin, which in girls will cause the release of estrogen and more testosterone in boys. So physical changes or puberty can begin between 8 and 14. It can probably stretch out beyond that though. And there are 5 stages of development during puberty: bone and muscle development and growth spurts. Pre-puberty is where the hormonal changes begin, but where no physical changes take place. And then this will step up through stage 5, where the reproductive organs and sex characteristics are developed, and facial hair may show up in boys. The levels of most hormones, as with everything, will decrease as we age. Some hormones will remain at levels found in young adults post-puberty, and some actually increase. Regardless of whether hormones rise or fall or remain the same, it generally is agreed that endocrine function will diminish with age. This is largely due to diminished hormone receptors on target tissues, making target tissues less sensitive to the circulating hormones. So some hormones that decrease with age would be growth hormone, estrogen and prolactin within the female, melatonin, which would explain sleep disturbances as we age, testosterone in males. Now, some that will remain unchanged would be our cortisol, epinephrine, insulin, T3 and T4, if they were balanced before. Some that will increase with age will be FSH, luteinizing hormone, norepinephrine, and parathyroid hormone. So some of the aging effects that we're going to see with decreased hormones, and this will explain a lot. Growth hormone will deliver us a decrease in muscle mass and strength. The thyroid, if this decreases, we're going to see a decrease in metabolic rate. This will contribute to eating pattern changes, temperature changes as we age. With estrogen, this will clue us into menopause, osteopenia, and osteoporosis. Estrogen has a lot to do with laying down bone, the bony matrix. Testosterone deficits will give us decreased muscle mass and reduced body hair, as well as loss of libido. Melatonin, sleep disturbances, and then what we can do for this in some cases, hormone replacement therapy, but that's not always the best idea because they can bring some unwanted side effects. So some diseases and dysfunctions we might see. We might see something called acromegaly or gigantism. It's rare, but overall body size, just a person gets really huge. So if you guys remember Andre the Giant, he had this. It's a tumor that presses on the pituitary gland, but it will appear gradually. It's treatments, there are medications to shrink tumors and decrease growth hormone levels, or you can get it surgically removed. Hypofunction of the pituitary gland. This will cause dwarfism. Dwarfism only impacts physical size. With diabetes insipidus, the kidneys will reabsorb water from the urine. So there's the loss of water and electrolytes and excessive thirst. This has to do, by the way, with an ADH dysfunction. So and when we say reabsorb water from the urine in this slide, we're saying that it's not, okay, pulling water back into the body effectively, okay? The antidiuretic effect has been lost. Hyperthyroidism, overactive thyroid, excess TSH can cause what is called as goiter or an enlargement of the gland. This can be from lack of iodine. It can be from cysts or nodules. It doesn't have to be cancer, but it will create inflammation. Graves' disease, we will likely see this in Graves' disease. Graves' disease will create a plethora of other responses. Generally in Graves' disease, a person has trouble gaining weight, okay? They will experience rapid pulse rates, high blood pressure, they're hot all the time. The treatments could be surgery, radioactive iodine, or thyroid drugs. And to get Graves' disease is autoimmune. Generally, you'll have what's called a TGAB test. It's an antibody test to see if your body's attacking the gland. In hypothyroidism, okay, there are multiple classifications of this. It's an underactive thyroid condition. Symptoms: hair loss, extreme fatigue, usually in the afternoons, by the way, sleep pattern disturbances. Did I mention you might have trouble losing weight? Cold all the time. You'll have hair loss also on the outer edges of your eyebrows, maybe even your caps. Dry skin. And when we say sensitivity to cold, this is beyond like you don't like the cold. It's pain induced from the cold. You can go on thyroid medication for this. Multiple forms out there. Also, you can have something called subclinical hypothyroidism, which is really before damage occurs. And you can actually correct that. In the 90 percentile of people diagnosed with subclinical hypothyroidism, you can do dietary changes and nutrient things and correct the situation before it turns autoimmune. So other thyroid disorders, something called myxedema. This is undiagnosed or untreated hypothyroidism, and the treatment is oral thyroxine. Neonatal hypothyroidism is a deficiency that develops congenitally or soon after birth. And again, treatment, oral thyroxine. When we have hyper or parathyroid disorders, okay, we're going to see hypercalcemia, which is a high blood calcium level. You might be prone to kidney stones. It will affect your nervous and cardiovascular systems. If you have hypocalcemia or low blood calcium, this can cause tetanus. It can affect your respiratory muscles. The treatment will be replacement therapy, vitamin D, and calcium. I want to point out here, within a lot of these disorders, there are nutrient treatments that can be very beneficial, even with a type 1 diabetic who requires insulin. They're going to be deficient in some nutrients and minerals, and you can really help their body do better with recovery, and really, pay attention to their inflammation response. If you can keep that inflammatory response down, you can likely change the trajectory of the disease and disorder. I'm not saying you'll ever be able to stop insulin, but there are some people that have radically changed the way they're doing things, and they can significantly reduce the requirement for insulin. As far as type 2 diabetes, which I began to talk about, didn't get very far in it, type 2 diabetic situation is more of a metabolic disorder, meaning can be controlled with diet and exercise. What's that mean? Reduce your inflammatory triggers, reduce your intake of simple carbohydrates, make sure you're active. This can significantly reduce all the hormone cascades. And there are definitely dietary recommendations that will drive you that way a lot faster. Okay, adrenal medulla disorders, remember, that's our catecholamine stuff. So we can, the body can have a manifested disorder called pheochromocytoma, which is a tumor in that medulla. And then we're going to have this hyperresponsiveness of our catecholamines. This can have life-threatening results due to the fact that it's stimulating fight or flight constantly. So it's going to have an impact on the lungs and the heart, and everything sympathetic will be hyper-inspired. The symptoms can be intermittent. They can resolve within 15 or 20 minutes. So immediate treatments may be that we need to bring that blood pressure down and then potentially removal of the tumor. Now, if you have a disorder of the adrenal cortex, Cushing syndrome, we're hypersecreting cortisol. I would say in here too, and it's not listed, but we have a hormone secreted here called DHEA. It's going to have an impact on what that cortisol is up to as well. We don't talk about it in here, but it's a real thing. Okay, if you have DHEA overproduction, that creates long-term cascade effects of not good stuff. The causes of Cushing syndrome or the disorder of the cortex could be ACTH, oversecretion, a tumor, or steroid drug use. Prolonged steroid drug use. Okay, so this could be, oh gosh, I can't even think of what it's called right now. When we have a severe allergic response and we go get cortisone. Okay, stuff like that. Addison's disease. This is a hyposecretion of these hormones, can be life-threatening. It's because what we will see if we have these hormones and hyposecretion, muscle atrophy, low blood pressure, kidney damage. We're going to have hypoglycemia, general feeling of weakness. And it's because of its impact on other organs and how that's able to inspire those blood pressure levels and what the kidneys are up to. Now, diabetes mellitus, I already talked through this, type 1 and type 2. The outcomes we don't want to see: kidney failure. Okay, that can happen with, chronic high blood sugars. Non-traumatic lower limb amputation, that is due to high blood sugar, chronic high blood sugar, okay, non-regulated. And what it will do is begin to necrose tissue. There's just way too much sugar and it's not being processed. It can impact the retina. It can make a person blind. You can experience heart disease. And this has to do with the inflammatory processes. These cascades take when there's excess sugar on board, and it can also produce a stroke. Now, I would say also with the management of type 2 diabetes, again, if you go into that diabetic ketoacidosis, you're in decay too long, you could go into a coma. You could die. Seizures are common with that. It's really the same on the other end of the spectrum. If through insulin management, there's an overdose, okay? You can just die from having no blood sugar on board, right? And everything shutting down. So blood test glucose monitoring, going for what's called hemoglobin A1C. Okay, they take kind of a 3-month look at where your blood sugars have been and they deliver it a numbers calculation. So what you'll notice is polyuria, polydipsia, and polyphagia. So a lot of urinating, excessive thirst, and drinking. Also excessive hunger, okay, because really it's a disease of starvation, okay, especially with type 1. Okay, type 2, you have plenty of sugar floating around, okay, but your body is just shut down to it. It's in a state of disarray. It doesn't want, the receptor sites in the cells don't want to open up, okay. Either they've been damaged or there's just, the cells don't need it. There's just way too much. And then your body starts doing funny things. With type 1, really, your cells are starving. Type 1, I already mentioned, there is a genetic predisposition. It's an autoimmune disorder, which is a hypersensitivity response of your immune system. It gets confused and begins to attack its own tissue due to something in the tissue that it perceives to be off or wrong. Now with type 2, again, it's a resistance. Those insulin receptors downregulate. Okay, too much going on, don't want to receive it. It says no. So then you have more sugar floating around in the blood and we need to take care of it. Another thing that is created with diabetes is peripheral neuropathy. It's the loss of feelings and extremities. I'm going to say it might not be the loss. Okay, you can have pins and needles, tingling, maybe pain. Now, if it really becomes necrotic and it's total loss, that's when the amputation comes. As far as exercise and even a type 1 diabetic is going to benefit from exercise in the way that their body will upregulate insulin use or glucose, insulin usage and glucose utilization. So exercise comes back to exercise all the time, doesn't it? Always, always. Again, I do support high levels of weight training, resistance activities. I just think that it does so many things if done well and right, which isn't really that hard to do.